Also, chocolate milk for kiddos goes great with activated charcoal. That was my random tidbit. But for the people that are listening to this recording now, do not forget airway is important. Do not leave it behind. If you have troubles with your building blocks, go back, start over, find the person that's going to explain it the best in the way that you best understand. And there's a reason that we do airway in the beginning, because it's one of the most important things. It's one of the first things we're always going to look at, but don't let it get left behind with everything else that you're going to learn. Okay, so we have what's called the ABCs. Have you guys heard of this before? So airway, breathing, and circulation. There's a reason that it goes in this order. If you don't have an airway, your patient's not going to do well, and there's not much that you can do for them after. Airway is most important with everything but trauma. Trauma, we look at CABC. And the first C in our trauma ABC is for hemorrhage, because hemorrhage is the #1 preventable death in trauma-related injuries. And most of that applies to external hemorrhage. So you want to stop the bleed, then do your ABCs. You don't want to let them bleed out and die and then say, oh, I need to look at the airway. So external hemorrhage, the only really internal hemorrhage that we're going to look at with that hemorrhage control in the first C of trauma is the pelvis. There's a lot of vasculature in your pelvis. So someone with a broken pelvis, you want to get that binder on, whether that's a sheet or an actual pelvic binder, to stop any internal bleeding.
Good. I was trying to, but the little bar was in the way.
And then if your paramedic gets down to it and you guys need to intubate in a trauma, or really any scenario, you're going to resuscitate before you intubate. And we'll kind of go over that tomorrow. But in general, your ABCs always come first. If you're like frozen and you're like this patient's horrible and they look horrible, where do I begin with? ABCs. You're going to get your groove in a primary assessments, vital signs, flow with your partner. But when in doubt, it's always your ABCs. And then in trauma, it's hemorrhage, ABC. For this chapter, just from the book, we're going to apply knowledge of general anatomy and physiology to talk about how it pertains to airway, adequate mechanical ventilation, and respiration of all ages. And then we're going to look at the physiology and pathophys of the airway, adequate versus inadequate, how to open it, use airway adjuncts, and then apply principles and techniques for suctioning in the proper way. Outcome-wise, we're going to look at the structure and function of the normal airway. We're going to compare concepts of airway pathophysiology. We're going to manually maneuver to help open an airway. And then we're going to look at making sure you have the adequate equipment and suctioning needed when it comes to airway management. Your book talks a lot about the anatomy of the respiratory system. In short, it's always made up of upper and lower. The upper part is going to consist of, in the diagram, generally your nasal cavity, nostrils, soft palate, hard palate, oral cavity, tongue, and then your laryngeal pharynx is the point of division. It's the entry point into your larynx, and it's protected by the epiglottis in your vocal cords. That's what is kind of the point of division. At that glottic opening where the vocal cords are, that split where the upper airway is compared to the lower airway. Tomorrow, when we talk about ventilation and respiration, the upper and lower airway will be important because it's going to tell us what portion is actually participating in gas exchange, how we can force air into there to help a patient, and what that generally looks like. So a lot of today will segue in tomorrow. So if there's something you really don't understand about today, please ask. It'll make tomorrow much easier when we go into more complex subjects. So there's just a picture of the general lower airway. This is an intubated view of that glottic opening and how things look for an airway. This is a typical adult airway. So you have different parts of cartilage. The trachea, that's where we want to get air in and out of. Cricoid rings, those are important for other reasons. your epiglottis up here and your vallecula, this is really big compared to this, right? And when we have to intubate someone, we actually have to lift either that epiglottis or the vallecula, depending on the equipment we're using. But I just wanted to give you guys the size of the trachea versus look how big that epiglottis is, because that's going to be important when we talk about airway positioning and causes of an inadequate airway. A lot of times I think when we talk about airway, we think about breathing and moving the patient's head and getting air down them, but it's also important to know why we're doing it, because all of this is on the inside. And sometimes that's hard to visualize when we're doing things from the outside. Make sense? Okay. So here are some different comparisons. I'm sorry if this is a little graphic for some people, but we have an infant, we have a toddler, and we have an adult. Differences in child, the mouth and nose are smaller. And this is significant because infants are typically nose breathers. They have larger tongues, and their trachea and chest wall are often softened and more narrow. So that means they're more likely to become obstructed just based on their anatomy. When we talk about inadequate airways, we talk about things like obstructions. So if you're like, well, how big is that? Like, that's on a PowerPoint. I'm not familiar with tube size and adults and infants, and what does that mean? This is a dime. An infant is around 4, an adolescent is around 6, and an adult is around 8. So the more we can manage the airway, the better it is for our patient. But when we talk about things like obstructions, secretions, just think about how easy it is to have an inadequate airway based just on the size of it alone. And then as you get smaller, obviously the harder it is. Does that help kind of picture how big things are on the inside that you're working with? So when we look at inadequate airways, some of these things can belong in other categories, but things that can cause an obstruction to your airway, something that can make it harder for the patient to breathe, that is not allowing enough oxygen to get through that trachea to adequately perfuse them. We can have blood, vomit, and secretions. We can have foreign objects. That can range anywhere from a food bolus, batteries are extremely corrosive and will eat away any tissue, to even teeth in a trauma. When someone has an altered mental status, when they're unresponsive, there's about 14 different muscles in your body that you're using at all times to keep your airway open. When someone loses that fight or flight response, loses that tone, and they're laying down, I'm sure you've heard that, like, their tongue chokes them and they die because they can't get air. It's not actually the tongue necessarily, but it's that epiglottis that falls and it can block their airway. So from that big picture we saw, the trachea and the epiglottis, their tongue technically pushes their epiglottis down, but a lot of different books or people are just like, the tongue blocks it. But also keep in mind that it is the epiglottis that, when we lose muscle tone, that's where we can have an airway obstruction, either from that epiglottis falling down or that tongue blocking it, especially in kiddos. Swelling, so trauma, and guys, keep in mind that trauma isn't just broken bones, right? You can have broken bones in your face and all the way through your neck and get a really bad airway, but it can also be burns. So if someone has soot in their nose, probably not a great sign. Burns cause a significant amount of swelling as well that can block it. And then crush injuries. So someone that gets their face or neck completely crushed is in a bad way. Group epiglottitis we talked about last week, where we saw that thumbprint and then the steeple sign, where we had those nearing, that can lead to obstruction. Other infections can cause it, anaphylaxis, bronchoconstriction and spasm, and then a mucus plug as well can cause inadequate airway. Cancer can also do the same thing, but typically someone that has head and neck cancer will get a tracheostomy put in, so it'll go below the cancer so they can breathe through that trach. There's not a whole lot of people that have trachs and Douglas that I know of. We get them every now and then in the ER, but just keep in mind that there's a reason they have this, and maybe it's good to investigate that when you're doing your background and your airway assessment. Questions so far? So signs of an inadequate airway where you can be concerned about it. Many of these we've talked about. Stridor, kind of that rubbing, leathery sound of it closing. Hoarseness, like when you sing too hard, your vocal cords rubbing together. Snoring, gurgling, wheezing, and gasping. Those are pretty self-explanatory. I think we've all experienced those in our own lives. They all mean different things, though. So make sure you understand the cause versus why it's sounding like that. So wheezing, where you have bronchospasm and constriction, you're going to hear that in asthma. If someone with asthma doesn't have wheezing, that's called a silent chest, and that is like impending doom. That's sometimes a test question out there. But wheezing, you're going to think of bronchospasm, bronchoconstriction. Your gasping could be a narrow, which you could be gasping and have stridor. Gasping sometimes also comes with choking as well, so something trying to move its way out of that respiratory system. And then your gurgling and snoring a lot of times depends on the patient's airway, and then if there's anything else like blood, vomit, secretions in there causing that patient to make that kind of noise. Any of those should cue you into, I need a further airway assessment, because there's a couple big questions you're going to ask yourself whenever you hear those or see a patient with inadequate breathing. That'll be on the next slide. But other signs and symptoms of an inadequate airway is basically what we talked about last week. Are they moving air? Is there any foreign bodies? A lot of this goes around the look, feel, listen. So you're going to look, are they breathing? You can feel their chest rise and fall, feel if they're moving air, and then you can listen if they're moving air as well. Whether that just be right next to them. I know that sounds super odd. That's a lot in BLS, or if you're actually listening with your stethoscope. So look, feel, and listen for all those symptoms, all those noises to cue you into. Your book says there's two main questions, which is the airway intact and patent, or is it open? That should always be your first question when assessing your ABCs in terms of your airway. The second question is, will it stay intact and patent? That failure to rescue comes with anticipatory instincts. So just because a patient may be doing well doesn't mean that they're going to do well later on. So you could have that kiddo with croup, and you're like, the ER got him stabilized, the airway's intact and patent, said the patient had stridor. They gave racemic epi, and the patient doesn't have stridor anymore, but you still notice that there's some nasal flaring and retractions. Like, okay, the airway is intact and patent now, cool. In the 45 minutes it takes you to Casper, or the most likely the 2 hours, 3 hours it takes you to Denver, and like gonna have further issues. So that's where your reassessments come in. You should always be doing chronic reassessments on the airway and documenting that you did them as well. And then I think there's always a third question. It's not always, is the airway intact and patent? And is it going to stay that way? What am I going to do about it? Or what can I do about it if further support for that airway is needed? And that's some of the things that we're going to talk about today. Any questions so far? All right, there's different ways that you can open an airway. I have some pictures, and we're going to talk about how to do each, and then we can give some demos just because that way you can actually kind of see how it's done. So the first one is head elevated sniffing position. When we think about sniffing position, typically we're talking about a child. In adult terms, oftentimes it's called ramping. And basically you're putting a bunch of stuff under the head, neck, and shoulders, or a combination of any of those, to get the tragus of the ear, so that little notch on the side, in line with their substernal notch, which is up here. And the point of that is that it's going to keep the airway in alignment better. It's not going to close it off and cinch it down. And then, because you're awesome partners for your paramedics, by helping position the patient that way, if your paramedic is going to intubate them, or you have a you suspect that that might be needed, that is a huge helper in actually being able to visualize down the airway. And that often gets overlooked, at least in the EMS scenes that I have seen. Not here, but out in the field. Just that ramping position or sniffing position will help keep their airway open, but it will also help set the paramedic up to be able to see better down into the airway. I have pictures of these because there's not really like a demo you can do. The head tilt chin lift maneuver, you will never use in a trauma patient. Okay, I shouldn't say never, that's like a test question. But that should never be your first option in a trauma patient, is the head tilt chin lift. Because your patient's laying flat, I think the book says take like 3 fingers on their forehead and then like 2 or your thumb here, and you're just gonna tilt it back, and then you're gonna make sure that you leave their mouth open. There's pictures there, we're gonna practice it, but you're basically tilting their head and chin back, leaving their mouth open. And that's just to get that airway aligned. But you're not going to do it typically in a trauma patient. The one that you're going to do in the trauma patient is the jaw thrust maneuver, where you're just going to lift up their jaw to help align that airway. And the reason is when you do the jaw thrust maneuver, you're not really moving any of that cervical spine. When you're tilting that whole head and chin back, you are. So if you have a suspected C-spine fracture, again, a lot of trauma patients here, or a lot of times we think of trauma like they get thrown out of a vehicle. It could be that little old lady that fell backwards in her chair at the care center. If there's any suspicion of a C-spine, if your paramedic's like, I can't rule out an injury to it, even if everything on assessment looks okay, and for some reason you need to support their airway, jaw thrust is trauma, not head tilt chin lift, because we don't want to hurt that cervical spine anymore. That's often a big like test trigger too, in terms of trauma and what airway you're going to use, airway positioning you're going to use. Make sense? So again, we'll practice all these, but this is the adult ramping position. So this whole airway down here, right, kind of cinched off. You also have a lot of extra tissue that you have to deal with. And then all of this extra weight is also going to make it harder to ventilate them or for them to breathe in general when they're that size. So here, are you going to have this many blankets and pillows in the ambulance? Probably not. So I've seen people use anything from saline bags to just like another pair of knees to pillows, like anything else that you can shove under there. One time we were in this house and we literally just used the bedding from the patient's bed, and that's what we had. But you're looking right here, that little tragus of the ear lined up with this sternal notch. That's what you're looking for. So if they're all like wonky on the bed and you're like, I don't know if that's right, just look at them from the side. That's all you're looking for. Does that help kind of make a better picture? So that's the adult version. Sometimes it's harder to see in adults too, especially obese adults, because there's a little bit more there, but children, a lot easier. You have to remember that children, especially infants, have a larger occipital region, occipital meaning the back of their head, that can be rounded. So that's why a lot of times you couple it, 1 with a headrest and 2 with something under their shoulders. And a lot of times that's rolling up a towel and putting it between their shoulder blades. But again, all you're looking for is that tragus and the sternal notch. And if you really look at it, it looks like they're trying to smell something. That's why it's called the sniffing position. For a little older demonstration where you don't need that extra padding under the shoulder, because eventually the babies will grow out of that larger occipital region. This one, they just have it under the head. Again, tragus with your sternal notch or suprasternal notch, depending on what reference you use. Does the sniffing position make sense? Okay, don't be afraid to practice this with your partners or whenever you're doing your clinicals, because positioning often gets missed. You like run into this emergency situation. I mean, you could just be helping in the ER, helping your partner, and you're worried about tubes and blood and spit and if it gets on you, but just position them and that makes all the difference. We get to go to a cadaver lab every year for flight, and they make us like do the different positions, and it is huge in how it maintains that airway. So please don't ever overlook positioning of your patient. All right, we'll practice the other ones in a little bit, but I feel like a lot of times when we think about airway and when we talk about airway emergencies, managing things, we get tunnel vision, and all of a sudden we just like want to support every single person's airway when we might not need to. Make sense? So for a short like tunnel vision reset is what I call them, we're going to go through a couple scenarios, and all you're going to think about is if you think you might need to help support that person's airway. So the first one, 27-year-old male, and these are all patients I've had. Any patients you see me talk about, I've had. So it is real. I try to make it as real as possible. So we had a 27-year-old male. He fell about 30 feet from a cliff. He hit multiple kind of jagged rocks on the way down. We controlled an external hemorrhage. His GCS was 3. You guys done GCS yet? Yeah. So GCS is your Glasgow Coma scale. 3 is the absolute minimum. 3 is really bad. 15 is us normal. And it depends on eye movement, their response to painful stimuli, and their verbal response. So he was completely unresponsive. That's what a GCS of 3 means. So again, he is unresponsive to even painful stimuli, and he has agonal gurgling respirations. Do you think we might need to manage this patient's airway? Yeah. So not only is he unresponsive, but he also has agonal gurgling respirations. He might have a lot of other things going on that the partner's gonna have to worry about, but the general key is we're probably gonna need to do something for his airway. Okay, 87-year-old male, achieved complete trouble breathing. He was just discharged from the hospital for a CHF exacerbation, congestive heart failure. He's alert oriented ×4. He can speak in full sentences, and he has some crackles in the left lower lobe. Do you think we're going to be needing anything for this guy's airway? Probably not. So we might throw some oxygen on him. We might need to give him a little supplemental oxygen, but he's oriented, so he's probably maintaining his own airway. He can speak in full sentences, which is a huge key of, does he not have too much oxygen? Is something impeding his respirations? But everything looks okay. So I don't think we'll be in the back of the bus or his house trying to maneuver his airway and put other things down to help him breathe. C, an 8-month-old female, high fever, cough, and thick mucus for 7 days. The urgent care calls you due to low SpO2 is 78%. No, they are not on oxygen when you arrive. Be warned, you will get called for low oxygen, and they will not have oxygen on that patient. She has retractions, nasal flaring, and labored breathing. She's tracking mom slightly, but she's otherwise very lethargic and appears to be drifting to sleep. Do you think her airway's open and patent right now? Yeah, barely. Probably not going to be. Do you think it's going to stay that way? No. So we're probably going to need to do some things about it, right? That's all we need to talk about right now for these. And then D, 35-year-old male. He was in a side-by-side, and then he went off a cliff, and the side-by-side landed face down. So when we got to him, that's where he was. He could still follow our commands, but when you look at his face, you could not tell where things were. So do you think we're probably going to need to help his airway? Yeah. With significant trauma to the face, we can suspect other things are bad have happened. So just because also someone can't see you and things look really bad doesn't mean they can't hear you. So please take that into account when you're taking care of patients too. But again, whenever you go through things, which I could have done a better job, is the airway intact and patent? Is it going to stay that way? And that is based off of your assessment. So how they are, vital signs, and then a good history on them as well. All right, we've talked about obstructions a lot. Your book does like a very short snippet on it, so that's all we're gonna do. They classify it as non-severe versus severe. Non-severe meaning some things can kind of move around it. They're getting some sort of airflow. Severe meaning that there's a complete obstruction. Abdominal thrusts are 1 year and older. The back blows and chest thrusts are less than 1 year. You guys have to take BLS before you take this class? Yeah. So some of that's just review. Keep in mind when you're doing your abdominal thrusts that it's the fist over the navel, then you put your hand over and they're quick up, kind of an in thrust. Don't like sit there and try to milk the obstruction out of them. I have seen that. Please do not do that. You're trying to shoot that sucker out of there. Make it quick, make it up. If they're pregnant, you just go slightly up. When you do your back slaps and chest thrusts, you flip baby, back thrusts this way. 1, 2, 3, 4, 5, kind of with their head down, right? And then you flip them to their front, and you're gonna 1, 2, 3, 4, 5, chest thrust them. Typically that's with 2 fingers. It's just below the nipple line. Oh, palm, whichever one.
And back blows for adults now.
Oh, so your back blows for adults. I guess I'm outdated. But for the chest thrusts that you're doing on the front, make sure it's half of the AP diameter. The AP diameter is how far around they are this way. So if you're going this way, it's half of this way in. If you're just like dinking around, that's not going to do much. That's kind of the general stuff on obstructions, and then you start CPR when they go unconscious. So you keep trying to clear it until you can't clear it anymore. If you guys are like, well, if they're, you know, they swallowed this or that and they're obstructed, what is my partner going to do? They can either go down there and look with some McGills and try to pull it out, or they're going to intubate and they're going to shove that all the way down into the right stem, and they're going to pull the tube back and they're just going to intubate the left lung, because one lung is better than no lung. So sometimes I feel like we think about things and then we see things and it's much different. So if you're like, oh man, the patient's obstructed, you know, he drank a penny or whatever, and all of a sudden you're like, why are they shoving things further down? One lung is better than no lung. And if you guys get to your practice and things really don't make sense, or you don't know why your partner did something with the way they did, please ask them after the patient. So if you saw your paramedic, you know, shove that penny down and then pull the tube back a little, and then you just ventilated one side of the chest all the way to the hospital, and you're like, this just doesn't seem right. Like, why did we push it further down? Take care of your patient, get your stuff ready for the next one, and then just ask your partner. You'll see some weird stuff out there, but it's better to know why something happened than just to not understand why. Sound good? Any questions on obstructions? When we talk about airway adjuncts, there are things that can help keep an airway opening after positioning. The 2 main ones in your book are your OPA and your NPA. Just looking at these, you can't tell, but the OPAs are very rigid plastic. You're not going to bend those. Your NPAs are going to be very flexible and soft. So if you're down to it, your partner's like, I need an OPA, and you know one's one and one's the other, and you're like, I can't remember which one, the OPA won't move. The OPA goes in your mouth, The NPA goes in your nose. So you'd rather have them biting on something that they can't chew through, if that helps you think about it that way. And then all of the different colors and sizes, they're made for how you measure them. So if you're like, how is the green different from the yellow? It's just how you're going to measure your patient and the one that you're going to use. And then before we start talking about how to use airway adjuncts, I like to keep in mind that preparation is key. That how you start your day, how you're prepping to do all these things is extremely important. So with any airway adjunct, when we have any kind of airway concern, suction is always going to get paired with it. So at the start of your day, there should be suction ready to go in case you need it, because ABCs, right? Airways first. So your suction should be one of those things you're checking. That you're opening the patient's airway manually before you put other things in them. That you insert the appropriate adjunct. And that even after that adjunct goes in, you're still positioning their airway. This is to further help it. It's not your catch-all. I can walk away and do other things from it. You can put the adequate airway adjunct in, walk away, and if that patient gets positioned wrong, their airway can still be blocked off. A lot of times we think, oh, I made them better because I put something in them. That's not the case. You still have to remember you're doing things step by step and for a reason, and you're not going to get lost because you just went to the next step. And then always continue to monitor. So again, when you're doing rig checks, whenever we take someone by ambulance, we have to do rig checks, but we do our flight checks every morning. The ER and floors should be doing their checks every morning. It should always have a suction and ambu bag close by, and then it should always have your airway adjuncts at minimum. You don't want to get on a call and not have suction ready and there's teeth and blood and all kinds of stuff flying around, or your partner's like, where's the OPAs? And you're like, oh, I forgot to put those on the bus today. Preparation is key, guys. Please do not forget that when you go out into your clinicals. All right. When we talk about an OPA, again, rigid, they're not going to bite through that. That goes in the mouth. You're never going to use it in a patient with a gag reflex, because then that can induce vomiting and then they can aspirate, meaning all that vomit goes into their lungs and then they get pneumonia and sepsis and die, in short. So if they have a gag reflex, don't use it. If you put one in and then they start to wake up and have a gag reflex, take it out and then position them and see where they're going to go from there. There's two general ways to measure. You're going to measure from the mouth to the jaw angle of the jaw, or to the tip of the earlobe. I find the angle of the jaw can be a lot different in people, but typically their earlobes are a little bit easier to measure from. So typically I do their mouth to their earlobe. And all you do is hold that up to them to see what size you need. Do you have a preference in jaw versus earlobe?
I always go from
Yep, because then you'll have like a no neck ed, and you're like, oh man, where's your job again? So you're gonna measure. When we do a cross finger opening, it's kind of like when you snap, but you put those fingers crossed in their mouth. I'll show you how to do all these, but that's just the next step. You cross finger to open their mouth. With an adult, it's actually going to be upside down. So the curved part's going to be like this. You're going to hit kind of their palate back there, and then you're going to rotate it 180 degrees for an adult. You can go 90 down, which is just fine too. With a child and an infant, because their airway is more anterior, meaning in the front, and superior, meaning a little bit higher, it's typically to go direct in. So you take a tongue depressor and it's curved like it normally is, and then you put the airway in. that way. And again, that's because an infant or peds airway is anterior, so more in the front, and superior more up. So if you go in backwards and try to twist things around, it's not going to do as much good. And then if you're like, well, I don't know if it's in all the way or if I use the right size, the flange, which is the very end of it, should be resting on their lips. And then after you put it in, you're going to maintain the positioning you had them in. When we wonder about if it's like, oh man, what happens if you put one that's too big or too small in? So the top one is an adequate size. They went to that angle of the jaw. B is too big. So when one is too big, it can kind of hit that epiglottis, and then all the air is going to be forced down into their stomach and in their diaphragm. If it's too small, it can pinch off that tissue, which is going to move down, and then it can block their airway that way. So that's why it's important to measure correctly. OPAs are very similar. You're going to do the nose to the tip of the earlobe or the angle of their jaw. Please use lots of lube with these, water-based, which I think that's how it all is, because you end up giving oxygen or something, oxygen's flammable. You use something oil-based, that can cause worse problems. But you're going to lose it up. Typically, they're made for the right nostril. All these studies show all different things, but there's a bevel on it, meaning that there's that little kind of opening, like they cut it at a diagonal. That bevel is going to go to their nair in the right side, to their septum, and you shove it in there and push it back. If you guys meet resistance, if you're like really wanting to shove it in there, please don't. Because when you force it, you're bound, first off, also to cause a nosebleed, and then you've caused more problems. But there's little turbinates in the back of your nose. Sometimes if you look in a kiddo's nose, it's those like huge little like tissue masses in the back. But the turbinates help us move air and kind of control foreign bodies that we naturally breathe. You can hit those turbinates and then you're not going to go anywhere. And then peds wise, you can be limited on what a child can fit through their nose. So that's why for infants and peds, it's not necessarily always the first line that you're going to go to. And then it's the same thing as the OPA. When it's too big, it can push things where it's going to go down into your stomach. Too small, it's going to pinch things and then just block it completely. You're not going to see it as much because of the placement, but it is a possibility if someone really puts in the wrong size. I think it's very dependent too on your partner and what you choose. Sometimes with seizure patients, if they're like really clutched down, whether it's a pseudo seizure or not, you can put those in at least. If you can't get their jaw to open.
Sort of facial head, neck.
Well, I think your book specifically notes it, and I know it's been a fair test question for my end, but if they have a basal or skull fracture, that's like definitely contraindicated. When you have a basal or skull fracture, it can actually tear your meninges and have spinal fluid leaking out or brain matter. And so you don't want to risk shoving an NPA or anything up the nose through that. Okay, do you guys have any questions on OPA or NPA? All right, supraglottic airways. Can they do supraglottic airways in Wyoming? Okay.
This portion of it is going to be for information.
Okay. So information purposes only, if you guys see them out there or not. You have a king airway, you have an LMA, and you have an iGel. A lot of times in surgery, we'll use the LMAs. These are all blind insertion devices. meaning that you don't need to get in there with a camera, a glyoscope, whether they're doing direct, and actually have to see the trachea to put that in correctly. It is a blind insertion device. And they do not actually enter that trachea. They just keep that glottic opening filled with space so that air can move through it. And then newer eye gels too, this end part where it is jelly actually will expand with the heat from the person. So I thought that was kind of cool. So that's how it also helps fill space. But these are blind insertion devices. They do not enter the trachea. When we practice, we can go over how they go in if we have one or if you guys wanted to. But really, you just position them, you do your cross finger, and you put it in there and you inflate your balloon and you see if you get chest rise and fall. Make sense? So another tunnel vision reset. Now that we've understand how we could position them, because we understand the signs and symptoms of an inadequate airway, we're going to anticipate doing that. And now we learn we can put more things in patients. Again, we're not putting everything in every patient. It's based on your clinical assessment and patient need. So if some of you guys are like very step by step or how you progress through things, this is kind of the typical way you're going to think of it. You're going to do your assessment. You're going to look at your ABCs or your CABCs in trauma. If things are bad, they have an inadequate airway, you're going to manually open it. You're going to think about an NPA or OPA. You're going to think about a supraglottic airway. You're going to think about an endotracheal tube. And then if that's not a possibility, then you're going to be thinking about crike. And can you do all of these? No. But is it important to understand this progression? Yes, because then you can help your partner if they can do these. Cool.
For their in our EMTs, they have. What's in Wyoming?
But for your test, your registry, you will,
Correct.
if you didn't hear that. So that's kind of the obvious progression. Does it mean that your partner isn't going to skip from ABCs straight to a tube or your ABCs straight to a crike? But when we think about what the patient could need more and more of, or say, you know, airway's not good, opened it, still not better. Put an OPA in, still not the best. Put a supraglottic airway in, doesn't work. Might need to go to an ET tube, might have to go to a crike. A crike is a type of surgical airway. So you make an incision in an adult, you make an incision here in the neck, you cut through the cricothyroid membrane, the whole process, bloody, and then you insert the breathing tube this way in their neck. That's really bad if someone's having to do a crike on a patient. So just kind of your logical progression, but again, it doesn't mean that you're gonna skip some of these steps or your partner might skip some of these steps. I do not, but we can pull some up on break. I know a lot of this sounds weird and looks weird, but the more we practice today, the more sense it'll make. And then also, when you guys put all these other devices in, we're going to go over more tomorrow, but just as a precursor, you always listen to belly, left, then right for your advanced airways, like an ET tube. Because you want to make sure you're not intubated the belly, that they go left, right, because a lot of times they'll right main stem it if something goes wrong, meaning that that tube followed more into the right lung than above where the carina is. But it's belly, left, right. We'll go over it more tomorrow, but those are important things to consider. And then never forget your end tidal. Alrighty, Suctioning, your minimum is 300 millimeters of mercury to consider that you have an adequate suctioning device. There's all different locations that suctioning can be. They can even be portable. Just be careful because at least all the portable or suctioning that I know of have like no battery life, and you're gonna get like a few good minutes, if that, and then you're gonna be toast. But still make sure you have portable suction in case you absolutely need it. And then when you're doing your rig checks and everything, this is just how I am. I know sometimes people are like, if you open the package, then it's dirty, but your suction should be set up. It shouldn't just be like, well, my suction container and is there, and the lid's here, and the tubing's here, and the yanker's here. Like, it should be set up so if anything bad happens, all you have to do is turn the suction on and suction them. It doesn't take long to set up a suction unit, but again, preparation is key. And there's also something called cognitive offloading, meaning however much extra you can take off of your brain that you're not going to have to think about leaves you more brain power to think about the patient. So instead of thinking, oh man, now I have to set up this suction and take away from other things, you have it set up and ready to go. And then different sizes and purposes. For pediatrics, when you suction them, it can actually cause a vagal response and their heart rate will go down and they can become bradycardic. So if all of a sudden you're suctioning a peds patient and they're bradycardic, you might have just stimulated that vagal response. Typically, when you take away the cause of it, their heart rate will get better. In pregnant patients have some of the hardest airways to manage, and they have some of the highest fail rates for intubations. One of the reasons is that all of the capillaries, so all those little blood vessels in that airway, become engorged because of the increased cardiac output and increased blood during pregnancy. That is more so for the intubation and adding extra airway adjuncts, but it doesn't mean that if you go to suction that pregnant patient, which would be pretty bad off if you're having to do that, that you're going to get a significant amount of blood at times. So please be extra delicate with your pediatric and pregnant patients, because worse things can happen than just your normal adult patients just trying to suction them. Also, not all suction canisters, suction devices are made up to do the same job. Typically, you're going to be able to suck up anything like blood, vomit, secretions, but don't sit there and try to suck up a tooth for 2 minutes. Find another way to get that tooth out if you're really worried about it, because you're not going to have enough suction to like grab it and pull the tooth out. So just be wary of that. You have to have enough power, and typically the 300 millimeters isn't going to get you enough power to suck out a tooth. You got to find other ways to do that. Whether it's a blind finger sweep, grabbing something else from your gills to get that out. But I have seen it, so please don't do that. General rules for suctioning. Your book gives you 3. Always use appropriate infection control practices while suctioning. You guys have this duty of very quick responses, ruling life-threatening emergencies out, getting that patient as fast as you can to a high level of care, right? But it doesn't mean what you do in that short term isn't going to have long-term impacts on your patient. One of the big things is that infection part. When we don't suction correctly, when we don't maintain an adequate airway, that patient can have stuff go in their lungs, and that's a huge infection risk. Or you can cut their mouth up more. You can cut their throat up more. That's an infection risk. So then they might make it through that initial trauma, but then die of an infection later on. So just the little things like that still make a huge impact on your patient in the long term. So yes, save them, do what you got to do. I know we not all have not done the most clean things in our jobs, helping patients out, because we have to do what we got to do. But if we can do little things like the infection control practices, that's what's best. Some of like the infection control practices, 1 suction unit per patient. Do not reuse suction equipment between patients. That's nasty. I've seen it. It's gross. Don't do that. If you can, try to keep the yonker like in the package, even if it's open and connected, try to keep it in there. Guys, if you see anything in or on your suction container, don't be like, oh, who left this for too long? You can do that, but just change it out, clean it. It's like you don't only want clean things for your patients. It's like you don't want to be touching that either, or have your partner be touching that. But the aspiration risk and infection risk, fair test questions, in my opinion, from what I've seen. Limit suction to no longer than 10 seconds at a time, and we only suction on the way out. With certain suction devices, like a yonker, it's always on. So that's a lot of like in the airway for things like a trach, for the nose. When we're going deeper, there's often a little port that when you occlude it, you have suction. When you don't occlude it, you don't have suction. And that's where you're threading the catheter in, then you have 10 seconds of suction. That's not only to reduce tissue damage, but whenever you're using suction, you're suctioning oxygen out of them as well. So that's a key component. So if you know you're going to be suctioning some oxygen out of them, if you can, maybe give them a little bit extra boost before you do. And then just general stuff. In an infant, do you think you suction the mouth or nose first? Are they primarily, yeah, they're primarily nose breathers. So you want to clear the main way they breathe out first before you go for the rest of it. Facial injuries, like JJ talked about, don't be putting stuff in a broken face. Just not a good idea. Obstructions, same thing. If you see something in there, grab it with your McGills or something else. Do not sit there and try to suction it out of them. It's not going to do any good. Dentures, typically you're going to leave dentures in, even if they're just partial dentures. If they get in your way though, then take them out. But typically they're not going to really move on you. They're not really going to obstruct anything. It's just a matter of, it's a little different with people with dentures in terms of how it feels. But try to leave those in. They're not typically going to bother you. When we suction patients too, don't be afraid, as long as there's not spinal concerns, to tip them on their side. Let gravity help you do some of the work. If they're like vomiting and you want to help suction some of that out, have them sit forward, let gravity do some of the work. It's also an aspiration risk just to leave them on their back, because all that blood is going to sit down there and then just go in their airway. Any questions? All right, that's all I have. We want to take a break and then we can practice.